Hello, everybody. Welcome to this discussion on how to approach a child with developmental delay. So, this topic has been divided into two parts. The first part is going to be looking at the history taking. So, how we're able to look at the different etiologies and the differential diagnosis of a child who's presenting with developmental delay. So, history taking becomes a very important part of this discussion because a lot of differentials can be eliminated only on the basis of history. So, we'll be looking into it at in great detail. And along with that, definitely, cerebral palsy is a common diagnosis. We see it very often, and it is again from an exam perspective one of the very common cases that are given. So we'll also just briefly look at what is cerebral palsy, and we'll understand the rest of it more in detail in the second session. So we'll begin with the history taking part, like all the other classes that we've done before. It's going to be, I'm going to be presenting a case like you would have in your exam. So we'll begin with that. So obviously the first slide or the first topic that you would talk about is the demographics. So let's say you have a 1.5-year-old male child, first by birth order, born of a consanguineous, a third degree consanguineous marriage, resident of Mumbai, informant being the mother who's reliable, has come in with chief complaints of convulsions. So we look at convulsions in detail. So you can say convulsions. Now, what happens as a chief complaint in a child who has developmental delay? So these convulsions could either be a breakthrough convulsion. So let's say the child already has a seizure disorder, has epilepsy, and has come to you right now with a breakthrough seizure. So that could be a possibility, or it could be the first episode of convulsion. That is also possible. So depending on what the history is, we'll have to kind of change the wordings of the chief complaints accordingly. The second complaint most commonly is delayed milestones noticed since what age? Now remember, when you mention this delayed milestones noticed since, you should never say noticed since birth, because milestones are something that the child develops as the age progresses. So probably the parents first noticed it when the kid was say 6 months old, when probably the child was not, head holding, or as compared to other kids or other peers, the parents realize that the child is looking delayed. So delayed milestones noticed since what age? But like I said, remember, never say delayed milestone noticed since birth. And although not very common, but a third complaint could be weakness or paucity of movements of, say, the right limb or the right side of the body, noticed since what age? So, affection of one side of the body in a case of cerebral palsy can happen in a hemiplegic CP, although it is not very common, but that could also be a set of chief complaints that the patient is presenting with. Okay, so like we saw, chief complaints in this case is convulsions, delayed milestones. So let's look at it in detail as to how do you take a detailed history of the presenting illness when it comes to these two chief complaints. So first one, history of convulsion. So what all do you ask when the chief complains the convulsion? So first and foremost, very important, you have to describe this episode of convulsion in detail. So you have to ask the mother or ask the informant how exactly did the convulsion look like. So was it in the form of tightening of the limbs? So was it involving all the four limbs? Was it involving one side of the body? Was it just involving one limb? Okay, that will tell you whether it's a focal or a generalized seizure. So whether the convulsion was in the form of tightening of the limbs or were there like jerky movements? Okay, so was it a tonic or a tonic-clonic convulsion? Whether or not it was associated with uprolling of eyeballs, bowel bladder incontinence, frothing from the mouth, how long that episode of convulsion lasted, was it a single episode or was it multiple episodes of convulsions, what was the level of consciousness in between those multiple episodes of convulsions. Why this is important is because it will give you an idea of whether you're dealing with just multiple episodes or status epilepticus. So in status epilepticus, the child will have multiple convulsions and he does not regain consciousness in between two episodes. So that's a way to differentiate status epilepticus versus just multiple episodes of convulsions. How was the post-ictal period? Was the child drowsy? Was the child awake? And how long did the post-ictal period last? If it's one episode, then you describe that. if there were multiple episodes, and you ask how many episodes did the mother notice and how long did each one last. Let's say the child is already having a diagnosis of seizure disorder or is known to have multiple episodes of seizures in the past. So in that case, you will ask that what was the age that the child first had convulsions? Okay, so convulsions since, let's say, 2 months of age, 3 months of age, whatever it is, or since the neonatal period. So if the child has had convulsions in the past, then what was the age at which the convulsions first appeared? And the last very important question is whether the child is taking any anticonvulsants, and if yes, and what is the compliance. Usually the parents will also know the name of the medication because the child is chronically on that one drug. So it's good. I mean, if you're able to tell what drug the patient is on, then yes. And very importantly, what is a compliance? See, what happens sometimes is probably the child has missed his doses of anti-epileptics, and that's why he's thrown a convulsion. So whenever you take any drug history, whether it's an anti-epileptic, whether it's an antihypertensive, whether it's steroid, whether it's anti-failure medications for a heart disease, whatever it is, it's always very important to ask about the compliance of the drug. So here you'll ask for whether the child is taking any anticonvulsants, and if yes, is the child compliant with those medications? So that's how you describe your chief complaint of convulsions in detail. The next uh, chief complaint that we had was delayed milestones. So delayed milestones noticed since, let's say, 6 months of age. How did the parents or how did the informant notice that the child had delayed milestones is when you compare it with the other kids. Let's say this child is probably second by birth order. So when compared to the elder sibling who's developmentally normal, the parents notice that the kid is a little slow. Or if the child is first by birth order, then the other kids in the family or the other kids in the neighborhood, the parents realize that that kid is able to do this, but my child is delayed. So how did the parents first like realize that the child is delayed, and at what age did they first notice? That is what you need to mention in your chief complaint. Having said that, so you can say that since the child has a history of delayed development or delayed milestones, I'd like to start with the antenatal history. Okay. So now from the antenatal history, we'll look more in detail at those questions which are pertinent to a case with developmental delay. Although the format is going to be pretty much the same, you have to ask questions with respect to the antenatal history, first, second, third trimester, birth, and neonatal history. Okay, so in the antenatal history, questions that are important and related to this would be what is the maternal age of conception? So it is said that mothers who are very young or elderly have a higher risk of, having kids with cerebral palsy. So if the mother is very young or if the mother is older, then it increases the risk of developmental delay. Next is consanguinity. So certain genetic and chromosomal disorders that can lead to developmental delay are autosomal recessive in nature. So consanguinity becomes an important question to ask for in that case. So first trimester, was it a spontaneous or was it an induced conception? So again, studies have shown that IVF and ICSI or IUI or intracytoplasmic sperm insertion, that's ICSI, have increased the risk of cerebral palsy. So whether the induction or whether the pregnancy was spontaneous or was it induced? If induced, then you need to mention what type of induction method was it, just IVF? Was it IUI? Was it ovulation induction, etc.? It's always good to mention those points if you have a history of an induced conception. Pregnancy was confirmed with a urine pregnancy test, let's say at 8 weeks of amenorrhea. The first dating scan was done at 10 weeks. The first dating scan is important because it is the most accurate in terms of telling you the age and the expected date of delivery. So to calculate whether the child was born preterm, term, post-term, the first dating scan is very helpful. When was the mother registered? Was there any history of fever with rash or post-auricular lymphadenopathy? Now, this uh, history is important to rule out torch infection. So we know that torch infections again can lead to developmental delay, microcephaly, seizures, cerebral palsy, all of these conditions. So this history of infections in the first trimester to rule out torch is very important. History of drug intake, radiation exposure, or substance abuse. So drug intake specifically, if the mother is, so when you say this history, probably you might be asked that what drug history did you ask for? So for example, if the mother is taking anti-epileptics, so phenytoin, if the mother is taking phenytoin, it can lead to fetal Hydantoin syndrome. Now, fetal Hydantoin syndrome is associated with microcephaly, mental retardation. So that drug history is important to ask for. Radiation exposure. So if you say that, you might be asked that what is the maximum radiation exposure that is permitted in pregnancy? So the answer is 500 millirads. That is the maximum amount of radiation which is safe, to encounter in pregnancy. So whether there was any history of radiation exposure and substance abuse. So cigarette smoking, tobacco, alcohol, all of these are associated with low birth weight, preterm births, and increased risk of placental insufficiency, which can lead to hypoxia and can lead to delayed development. So, history of drug intake, radiation exposure, and substance abuse. The last question is whether the mother had history of excessive vomiting, also called as hyperemesis gravidarum. Why is this important? So, what happens is some mothers who have severe vomiting might be started on pyridoxine because it kind of helps with the vomiting. And when the mother is taking very high doses of pyridoxine, it can lead to pyridoxine dependent seizures in the newborn. See, this is again very rare. I would say it's not something that happens very commonly, but it is a possibility. So, if the mother has had a history of hyperemesis gravidarum and has received very high doses of pyridoxine, this is another thing to consider in a child who's having seizures in the neonatal period. Now, in the second trimester, when the mother started, noticing or feeling the fetal movements of quickening, any history of medical illness like hypertension or gestational diabetes mellitus. Now, why is this important? Both PIH and GDM increases the risk of placental insufficiency. So, impaired perfusion of the fetus causing increased risk of hypoxia. And we know hypoxia is harmful to the brain. So, when you don't have enough amount of oxygen going to the brain, it's harmful. So, hypoxia can lead to developmental delay. Okay, maybe the child has not cried at birth, and there is hypoxic ischemic encephalopathy, which eventually leads to a permanent brain damage. So whether there's history of any medical illness. Ultrasound scans, most importantly, so the anomaly scan is done in the second trimester, somewhere between 16 to 18 weeks of gestation. So whether the anomaly scan was normal, so certain um developmental anomalies of the brain, like you have holoprosencephaly, lysencephaly, etc., can be picked up on the anomaly scan, which is done in second trimester. So you will ask the mother whether the anomaly scan was done. If yes, was she told that there is some abnormality on the scan or it's normal? So anomaly scan, we've discussed this in the discussion on the newborn history taking, but how do you ask the mother whether she's undergone an anomaly scan? So she might not know the term anomaly scan. So this scan is usually done in the second trimester, somewhere between 16 to 18 weeks of gestation, and usually the scan takes very long. Okay, it takes about 30 to 45 minutes because each and every part of the body is screened in great detail. So you can ask the mother whether कोई बड़ा लंबा sonography का जांच हुआ था क्या. Probably she might be able to correlate that with an anomaly scan done in the second trimester. So that's basically how you would ask the mother if an anomaly scan is done or not. History of iron, folic acid, calcium supplementation, whether immunization was received, and whether there's any history of bleeding or leaking PV. Third trimester, bleeding for vaginum, so might point to either antepartum hemorrhage because of placenta previa or abruptio placenta. Again, these lead to placental insufficiency, hypoxia, and can lead to HIE. Very important question is whether there was any leaking of foul-smelling liquor to look for chorioamnionitis. So any infection in the mother, whether it's chorioamnionitis, whether it's an ascending infection like a UTI, all of these can affect the fetus, can cause infection in the fetus, which can lead to meningitis in the neonatal period, which can lead to sepsis and again damage to the brain. So infection in the mother, whether the mother has had any fever or any UTI, diarrhea, foul smelling liquor, all of this is important because all these conditions can predispose to developmental delay. How was the perception of fetal movements? Again, third trimester, PIH, GDM, and hyperthyroid or hypothyroidism is again important. So hyperthyroidism again is a risk factor for cerebral palsy. So again, these medical conditions to ask for in the third trimester. How was the weight gain? Uh, whether there were any whether there were any ultrasounds done in the third trimester, and whether there was any abnormality detected on that, whether there was polyhydramnios, oligohydramnios, anything else that the mother was told for, and whether there was any history of magnesium sulfate given in the third trimester. Now, how do you ask for this history of magnesium sulfate, and why is it important? So it's important because magnesium sulfate is known to have neuroprotective benefits. Okay, so when the mother is at a risk of a preterm delivery, usually magnesium sulfate is given because it has been shown to prove to be neuroprotective for the fetus. Okay, so it decreases the risk of neurological complications of the fetus if the mother has received magnesium sulfate. Okay, having said that, how would you ask the mother, or how would the mother know whether she really received magnesium or not? So magnesium is given as continuous IV infusion over 24 hours. Okay, there's a loading dose and then there's a continuous infusion dose. Obviously, you don't need to know that, and the mother is not going to know. But it is given as a continuous infusion over 24 hours. So probably the mother might know that there was some IV medication that she was kept on continuously for 24 hours before she delivered, and magnesium sulfate is given when there's an anticipated preterm delivery. So specifically, if the child was born preterm, you should ask about history of magnesium sulfate. So it's highly possible that the mother really doesn't know whether she received it or not. But if she gives you a history, it's going to be a good add-on point. So it's good if you're able to ask and the mother is able to give you a history. And that's why that's something that we always tend to ask whether magnesium sulfate was given in the third trimester just before delivery. Now, birth history, what is the gestational age? So this is again important because preterm kids are again at a higher risk of CP. Now, again in preterm, what type of CP is more common is the spastic diplegia as compared to the other types of CPs. Why is it so? It's because your leg fibers run in the periventricular area, and periventricular leukomalacia or PVL is commonly seen in preterm babies, and that's why the fibers that supply the lower limbs, which are periventricular in location, are affected in preterm kids, and that's why spastic diplegia is the most common type of CP seen in this population. Having said that, the preterm kids are in general at a higher risk of having CP, and they can also have other varieties, like they can have spastic quadriplegia. But out of all the types, spastic diplegia is the most common. What is the birth weight? So again, IUGR, low birth weight in preterm babies are again at a higher risk of CP. But what is the place of delivery? Whether the mother delivered in the hospital, or sometimes it's possible that the mother delivered at home or delivered on the way to the hospital. If that is the scenario, then who conducted the delivery and whether the child cried at birth or not is very important. Whether it was a vaginal delivery or a section, was there a history of instrumentation? History of prolonged labor, again very important. Now, what is the definition of prolonged labor? So, from the onset of labor to the time the delivery happens or the fetus is expelled out, if that period is more than 12 hours in a multi or more than 18 hours in a primary gravida, that is known as prolonged labor. Why is it important? Because prolonged labor again predisposes to the risk of infection, and infection, like we just saw, increases the risk of sepsis, meningitis, and CP. So, was there history of prolonged labor? That's very important. And so, you will ask the mother when she started feeling the labor pain and when she delivered, and you calculate the number of hours that span between these 2 points, and that will tell you whether there's a history of prolonged labor. Next is premature rupture of membranes. So premature rupture of membranes, how do you define that? When the rupture of membranes happens before the onset of labor pain, that is called as premature rupture of membranes. So when that happens, again, because the labor pains have not set in, the uterine contractions have not set in, there's an increased risk of ascending infection, chorioamnionitis, UTI, sepsis, infection, meningitis. Whether there's an history of meconium stain liquor. Now, again, meconium stain liquor, when let's say the child has aspirated that meconium stain liquor, there's a risk of meconium aspiration syndrome, sepsis, meningitis, infection, developmental delay. Very importantly, whether the child cried at birth. If not, then what kind of resuscitation steps does the child need? So usually what happens if the child has not cried at birth and has required resuscitation, but it's just in the form of tactile stimulation or some amount of oxygen support or chest compression or whatever, we tend to tell the parents what resuscitation efforts were required at birth. So it's it's good if the parents know and they have been informed as to what steps were taken. It's also possible that they really have no idea of what resuscitation, but definitely the child did not cry at birth and required some kind of resuscitation. So even if that history is there, it is significant because again, not cried at birth causes hypoxia and can lead to hypoxic ischemic encephalopathy. Now, once I say that, let's say you don't have a history of child not crying at birth. So let's say the pregnancy was uneventful, the birth was uneventful, the child cried immediately at birth. If I say that, can it still be cerebral palsy? I mean, can you still have a child who's had an uneventful pregnancy and a birth period really develop cerebral palsy later? So the answer to this is yes. That's because birth asphyxia as a cause of cerebral palsy accounts for about 10 to 20% only. The other 80% of causes that can lead to cerebral palsy are prenatal and postnatal causes. Okay, so birth asphyxia, although increases the risk of CP, a lot of CP kids do not have birth asphyxia. Okay, so if you don't have a significant birth history, you can still have the child with cerebral palsy. So this is something we know that examiners might ask you that the child is cried at birth. Would you still keep your diagnosis as CP? The answer is going to be yes, because birth asphyxia accounts for only 10 to 20% of causes of cerebral palsy. Now, in the neonatal history, whether the child had an NICU stay, if yes, how long and what kind of treatment did the child receive? In terms of whether the child received oxygenation, ventilatory support, IV medications, blood transfusions, any procedures were done, let's say a lumbar puncture for maybe to look for meningitis, etc. So, how long did the child stay in the NICU and what kind of treatment did the child receive? Whether there was an history of mechanical ventilation, history of neonatal seizures. Now, neonatal seizures is again very important because the earlier you have seizures, um I mean, it's the differential diagnosis of a neonatal seizure is going to be different. The causes are different, and again, every time there's a convulsion, that amount of hypoxia that sets in the brain is going to be detrimental in the long term. So whether there was any history of neonatal seizures is important to look for. History of jaundice. So if the jaundice is uncontrolled, very high, maybe the child presented very late, it can lead to kernicterus. Now, kernicterus permanently damages the basal ganglion and it can predispose to a particular type of CP, which is a dystonic CP, because the basal ganglion basically is involved with the tone and movements. So when you have affection of the basal ganglion, which can happen in kernicterus, which is uncontrolled uh, hyperbilirubinemia and permanent damage of the basal ganglion, it can lead to dystonic CP. History of hypoglycemia. So hypoglycemia again can lead to convulsions, and hypoglycemia specifically damages the occipital lobe. So it can lead to cortical blindness. So whether the child had a history of hypoglycemia in the neonatal period. History of fever, irritability, altered sensorium, refusal to feed could be a presentation of sepsis or meningitis. Whether the child was started on any anti-epileptics in the neonatal period, if yes, then if the parents know which one, it's good. And when was the feeding established and the difficulties? So let's say the child has had a stormy NICU course, was probably did not cry at birth, required resuscitation, ventilation, circulatory support, had a good 1 month NICU stay, was initially fed via RT and then probably later on established breastfeeding. So in that case, if the child is has suffered significant HIE at birth, then probably there will be difficulties with establishment of breastfeeding. And that's why it's important to know that, what was the feeding pattern, when was it established, what difficulties did the child have with feeding? I mean, was he able to latch on? Was he able to feed well? So if you have a history of feeding difficulties and establishment of feeding, which is difficult in the neonatal period, it will tell you that probably the child is more sick in terms of their motor and coordination aspect, and probably, maybe it will lead to poorer prognosis. So after your antenatal and all of that history, next history is going to be extremely important in this case, which is your developmental history. So how do you kind of uh, give a detailed description of the developmental history, and how do you summarize it at the end? So obviously, you will first have to mention all the milestones that the child has achieved till now from the neonatal period, depending on what the age is. And you will have to describe it in all the four domains, which is your gross motor, fine motor, social, and language. After mentioning what milestone the child has achieved, so it's always good to know what is the last milestone that that the child has achieved at that age. Let's say the child is 1.5 years old and has just started rolling over. Okay, so then how do you calculate the developmental quotient? So developmental quotient is the developmental age upon the chronological age into 100. So let's say the child is 1.5 years old and has just started rolling over. So probably the age is about 6 months. So developmental age in this case would be 6 months. Chronological age would be 1.5 years old in 200. So that is going to be your developmental quotient for the gross motor aspect. Similarly, you need to calculate the DQ for fine motor, language, and social, each one. So at the end of your developmental history, you will say that the developmental quotient for the gross motor is 30%. Developmental quotient for fine motor is 40%, etc. So you will have to mention the DQ of each and every domain. Why is this important? Is because in certain types of cerebral palsy, certain areas of certain areas of milestones are more involved or more affected as compared to the others. Like for example, in a spastic diplegia, your motor and your language and social milestones might still be preserved, but what is most affected is your motor, is your gross motor and fine motor milestones. So you will see a discrepancy in the DQ of your motor milestone versus the language and social which will be much better in a case of cerebral palsy of the spastic diplegia type. If you have a spastic quadriplegia where you have affection of all the four limbs, these kids usually have poorer prognosis, and maybe in them their affection of social and language milestones might be as bad as the motor milestones. So that is why knowing a DQ of each and every domain of the milestones is very important. After mentioning the DQ, next important line that you should always mention is that the hearing and vision, according to the mother, is normal or abnormal. Let's say the mother tells you that I feel that my child is not able to hear me. So a child who has impaired hearing will have delayed development of milestones just because he's not able to hear. Okay, so you always need to ask the mother or the informant whether she feels or he feels that the child is able to see and at least hear well. So how do you ask whether the hearing is normal? Is whether the child is able to turn his head to the sound, or if you call the child, does the child look at you? In terms of vision, whether the child is able to kind of make eye contact, probably even recognize the parents. The hearing and vision is something that you always have to mention at the end of developmental history, not just in this case, but in all other pediatric cases. So then you calculate the DQ for each domain. Now, when I talk about normal development, so normal development is defined as a DQ of more than 70%. Developmental delay is when your DQ is less than 70% in any of the domains. What is the definition of global developmental delay? So when you have delay in at least two domains out of, so we look at domains as gross motor, fine motor, language, and social. But when we're talking about global developmental delay, we club the the fine motor and gross motor into one. So when the child has delay in the motor along with either social or language, then we call it a global developmental delay. So there has to be a delay in at least two domains where gross and fine motor domains are considered as one. So you might have uh, delay in say gross motor, I mean say motor and language, or motor and speech, or motor, language and speech, everything. So that's when you say that the child has global developmental delay. So this is a question that they can ask you that what is the definition, or when do you say that the child has GDD? It's important to remember that the term global developmental delay is used till 5 years of age. After that, if the child has delay, like global developmental delay, it's called as intellectual disability. So just the terminology is different depending upon the age. And after having calculated the DQ for each and every domain, you need to give an overall DQ. So take an average of all the four DQs. And so let's say the overall DQ for this patient was 50%. I mean, not percent, was 50. So in that case, you have to say what is the grade of retardation. This is what it is. So above 70, like we saw, is normal. So 50 to 70 is mild, 35 to 50 is moderate, 20 to 35 is severe, and less than 20 is profound. So when you calculate an average developmental quotient at the end of the four DQs, you will say that the child has an overall DQ of this and falls into the category of, say, like for example, moderate retardation. Another important history to ask for when in terms of milestones is whether the child has any advanced milestones. Now, let's say, for example, take an example of handedness. Now, handedness usually appears after 2 years of age. But in CP, let's say maybe hemiplegic CP, the child develops handedness as early as say 1 year. So the child has developed milestones earlier than he should have. So that is called advanced milestones, which is a red flag and points to some kind of developmental abnormality. Very important point to mention is whether there's a history of regression of milestones. Now, what do you mean by regression of milestones and why is it so important to us? When the child has a regression of milestones, so when I say regression, as the word suggests, it means that the child has achieved those milestones and has started losing them now. So let's say the child was able to, you know, sit without support, probably even walk, and now he's not able to even roll over. So this is what I mean by when I say regression of milestones. So he has achieved age appropriate milestones and then has started losing them. That is what is regression. Why is it so important? Is because a regression of milestones points to a completely different set of diagnosis, which is the neuroregression disorders or neurodegenerative disorders, as we call it. CP is a static encephalopathy, so you will have delayed achievement of milestones in CP, but you will not see regression of milestones. So maybe the child will not be able to roll over at say for like 5 to 6 months. Maybe he starts rolling over at 1 year. So there will be delayed achievement of milestones, but you will never see regression of milestones. But there is a term called as pseudo regression of milestones. So what do I mean when I say that? So what happens is in children with CP, especially the spastic CP, which have increased tone, so they're able to achieve their milestones, obviously, which are delayed as compared to normal kids. But what happens is they tend to lose one or two milestones after a certain age. So, like for example, you have a child with spastic quadriplegia. Okay, he was able to sit without support at say 2 years of age. But now, because of increased spasticity, the tone has increased. The child has developed contractures. Maybe the child is not receiving physiotherapy, occupational therapy, or muscle relaxants or whatever, and the child has developed spasticity. What happens is now he's not even able to roll over at 2.5 years of age. So then you would say that, oh, he achieved that milestone, but now has lost it. So this is what is known as pseudo regression of milestones. And how do you differentiate this from regression? Is that when we say regression of milestones, it affects all the domains, whereas pseudo regression of milestones will affect one particular domain, and there'll be one or two loss of milestones. So that is how we differentiate pseudo regression versus complete neuroregression, because you can have pseudo regression in CP, but when you have neuroregression of milestones, it cannot be CP. It will lead to a different set of diagnosis, which is your neurodegenerative disorders. Okay, so that is why you should always mention whether there's any history of regression of milestones. So at the end, when you summarize your developmental history, you will say that the child has global developmental delay if there's a delay in more than two domains, with the grade of retardation that we just saw, depending on what is your average DQ at the end of your calculation. And always mention one point saying that the child has normal vision and hearing. So moving ahead, now what is important in any CNS case is that along with this normal history taking that we do like other cases, there are set of questions in a CNS case which are pertinent to how you would examine the case, in the examination. So in a CNS examination, we go ahead with like higher mental functions and cranial nerves, motor, sensory, cerebellar, autonomic, spine, etc., etc. Right? That is how we examine the child for a CNS evaluation. Similarly, there are set of questions that you need to ask with the same headings in any CNS case because that will tell you exactly the localization of the anatomy, the pathology, and will give you a clue about the etiology. Like, for example, so when we talk about history related to higher mental functions, so you ask the mother if what is the level of consciousness. So whether the child recognizes the mother, is interested in the surroundings, plays well, or is having behavioral abnormalities like irritability, hyperactivity. Okay, so irritability, hyperactivity, autism, all these are associated features with CP. So any behavioral abnormalities, any seizures. Now seizures is important because CP is a disorder affecting the cerebral cortex, and that's where you have your origination of seizures. Okay, seizures are basically abnormal electrical impulses that generate in the cortex. So if you have seizures, it means that your lesion is somewhere in the cerebral cortex. So whether the child has any history of seizures, and what is the speech like. So when there's um spasticity, it can lead to dysarthria, which means that you don't understand or it's in unintelligible speech. Okay, so that happens because of spasticity. So speech is something that you need to ask the mother whether the child has is able to communicate and whether the speech is normal or is dysarthric. Okay, so this is questions related to the higher mental functions. Now, with respect to cranial nerves, so obviously we'll look at questions again with respect to nerves from like 1 to 12. So whether there's any history of visual abnormalities or squint. So that's again your 3, 4, 6 cranial nerves. Visual abnormalities can also happen with the involvement of the optic nerve. Uh, to look for questions, to look for involvement of your facial nerve, whether there's a history of facial asymmetry, inability to close your eyes completely, facial drooping. History of hearing difficulty. So whether the child is able to turn the head to the sound or respond to the name to look for the eighth nerve, and history of difficulty in swallowing, nasal regurgitation, nasal twang, drooling of saliva, etc. for the ninth and 10th cranial nerves. Okay, so when you have involvement of the lower cranial nerves, like seen in pseudobulbar palsy, excuse me, the pseudobulbar palsy happens when there's involvement of the corticobulbar tracts. Okay, so it can lead to UMN type of symptoms involving the lower cranial nerves. So your involvement of difficulties with swallowing, nasal regurgitation, change in voice, nasal twang, etc., can point to involvement of the ninth and tenth cranial nerve in CP, which is seen in pseudobulbar palsy. Okay, so now another question would be, why would a kid with CP have visual abnormalities? So maybe causes like infections, like torch infections, where you have rubella, CMV, all of these can lead to visual abnormalities. Now, squint is something which is very commonly seen with spastic diplegia. We'll look at this more in detail as we go ahead and especially in the examination part. But squint is a common association with CP, again, most commonly with spastic diplegia. All of these other cranial nerves can again be involved depending on what is the lesion and what is the etiology of the delay that we're talking about. And that's why uh, cranial nerve involvement is important to look for, especially when you're talking about rehabilitation and the kind of therapy that the kid needs in the treatment. And again, like we saw, pseudobulbar palsy is important and is commonly seen affecting the lower cranial nerves. Now, history related to the motor system. So most commonly, these kids are going to have spasticity. So you will ask whether the mother has any history or mother faces any or difficulty while putting on the diaper, or whether the child has any scissoring. So scissoring and your commando crawl. Okay, all of this happens because of spasticity and adductor spasms of the lower limb that is seen in spastic diplegia. So whether the mother has any difficulty in putting on the diaper, the child has any scissoring, or there's tightening of all the forelimbs like in spastic quadriplegia, or the motor system is involving one half of the body that is seen in spastic hemiplegia, whether the child is tiptoe walking, that could be because of contractures. So CP basically is a disorder of the motor system. So when there's increased tone, depending on what uh, what limbs are involved, whether it's involving the lower limbs, involving all the four limbs, involving one half of the body, you'll be able to say whether this is a type of spastic diplegia, quadriplegia, or hemiplegia. History of involuntary movements or dystonias. So what do you mean by dystonia? Dystonia basically sudden stiffness of the limbs when you're trying to handle the child. Okay, and the child goes into opisthotonus. Involuntary movements again point towards affection of the basal ganglion. So when you have a dystonic CP, affection of the basal ganglion, putamen, all of those structures, you can have involuntary movement. Now, hypotonia in terms of floppiness, or when you try to pick up the child slips from the hand while holding. Now, these are points towards hypotonia. Now, you can have hypotonia in a child with CP as well, so atonic or hypotonic CP. Although not very common, but whenever you have a motor system involvement, it's always important to ask for whether the child is having increased tone or hypertonia or hypotonia. Whether there's an history of wasting or thinning of the muscles because of disuse atrophy. So let's say the child is having spastic quadriplegia, is having excessive tone, spasticity, and the child is not receiving adequate amount of physiotherapy. So movement is not adequate. So what happens? He's not able to use those muscles, and at the end they undergo wasting and atrophy. So the more muscle atrophy that you see, probably the child has not received the kind of rehabilitation that he should have, and points towards disuse atrophy. So this is questions that you will ask related to the motor system. Now, with respect to sensory, whether the child is able to perceive touch pain and appreciate cold or hot, depending on the age. So, in terms of a smaller child, you will ask whether the child is able to perceive touch and pain. In an older child, hot and cold temperature is something that you can ask either the informant or the child himself. Now, history related to cerebral symptoms, so that there's an history of ataxia, intentional tremors, nystagmus, to localize the lesion to the cerebellum, which can lead to ataxic CP, and history of autonomic system involvement, like the bowel bladder disturbance. So, uh, your autonomic system is basically taken care of by the hypothalamus and the surrounding structures. So kids with cerebral palsy have shown to have involvement of the autonomic system in terms of hypersalivation, tachycardia, cardiovascular instability, hypotension, etc. So bowel bladder disturbances is one of the most common autonomic disturbance that you see, and it is often a complication, or you can say like comorbidity in these patients. So that is something that you should always ask for. So this was history related to the CNS, where we asked questions pertaining to the higher mental functions, cranial nerves, motor, sensory, cerebellar, and autonomic. So that kind of completes that chunk of questions related to the CNS. Now going back to history, taking like any other case, what is the history of complications? So what complications would you expect in a child with developmental delay, or to be more specific, let's say cerebral palsy? So history of constipation or UTI because of bowel bladder involvements. History of bed sores or contractures because the child is immobile, probably not receiving the kind of rehabilitation that he needs. History of feeding difficulty. So feeding difficulty can happen because of involvement of your lower cranial nerves. So there's difficulty in swallowing, nasal, like drooling of saliva, etc. History of repeated respiratory tract infections because of aspiration. So there's impaired reflexes. So maybe the gag reflex is impaired. The child is constantly in the supine position, is having poor oral hygiene. All of this can predispose to repeated respiratory infections. Now, history of hyperactivity, emotional disturbance, sleep disturbances. All of these behavioral abnormalities are commonly seen in children with CP, and they also need to be uh, diagnosed and treated accordingly. So behavioral abnormalities is something that you should always ask for, whether it's a history of complication or whether it's a history related to the higher mental function. Very important next step is to classify the child depending on what is the gross motor functional capacity scale, GMFCS. So this level is needs to be mentioned in a child who's more than 5 years old. So what are the different levels of GMFCS scale? So you have 5 levels. So let's kind of look at the picture along with the description. So in level 1, the child is able to walk without restrictions, but has certain limitations with more complex and advanced motor skills. In 2, he's able to walk with assistive devices and limited activity in outdoors and the community. In level 3, he's able to walk with handheld assistive mobility devices and limitations in walking outdoors and community. As you go ahead, uh, the severity gets worse. So in level 4, you have self mobility with limitations. Children are transported or use power motility outside. And level 5 is the worst, where you have self motility is severely limited, even with the use of assistive technology. So you need to kind of ask the mother what the child is able to do at his age and then give a level of GMFCS scale of involvement. So let's say the child is able to walk with just a wheelchair or with just little kind of support, or is able to, once put on a wheelchair, is able to drag himself from one place to another. That would be GMFCS level 3. So the more the level, the more severe is the motor involvement. So after having enumerated your developmental history and your motor system, when you talk about complications, you should always mention what is the level of GMFCS scale that the child is able to do currently. Also, why this is important is it will tell you how bad is the involvement of the motor system. And when you're trying to start your rehabilitation services, it's important because you want the child to move to a lower grade. Okay, so you want the child to be at least able to take care of himself on his own without any support, without any help. So the moment you start your service, your rehabilitation of the physiotherapy, occupational therapy, speech therapy, etc., you will try to get the patient or the kid back to a lower level. So GMFCS scale is important for diagnosis and for prognosis and follow-up perspective. Now, having discussed all of this history, what are the risk factors for cerebral palsy? So, very important to know that 80% of cases are caused because of an in utero brain injury. 10% occur at the time of birth. That's what I said. Your history of hypoxia, not crying at birth, requiring resuscitation, is only 10% of those cases who will eventually develop CP. And 10% get involved in the first year of life. So the insult happens in within the first year or the infantile period. So 80% in utero, 10% at birth, 10% within the first year of life. So what are the prenatal risk factors, perinatal and postnatal? So prenatal maternal malnutrition, torch infections, multiple pregnancies, PIH, hypertension, hypothyroidism, substance abuse, drugs, etc. are prenatal risk factors. Perinatal, prolonged labor, premature rupture of membranes, hypoxia, prematurity, low birth weight, etc. Postnatal would be meningitis, encephalitis, seizures, hypoglycemia, trauma, colitis, etc. So these are the risk factors for cerebral palsy, which have been noted down in the IAP Standard Treatment Guidelines 2022. This is a snapshot of those guidelines. So this is something again which can be asked, that what are the risk factors of CP? So when you're asked that, you need to classify it as like antenatal, perinatal, and postnatal factors. Now treatment history, very important as to what all investigations have been done till now. So let's say the child is having a history of seizures. So whether the child has received any neuroimaging, whether an MRI has been done, whether the child has had an EEG to look for seizure activity, etc. What kind of drugs the patient is on. So anti-epileptics and muscle relaxants for spasticity. So you have baclofen, diazepam, etc., which are given for spasticity. So that the child is receiving any of those medications. And again, I'll like to reiterate that when you have a history of drug intake, always ask for the compliance. Most important in a child with cerebral palsy is rehabilitation. So physiotherapy, occupational therapy, speech therapy are the mainstay of treatment when it comes to dealing with a child with cerebral palsy. So when you talk about physiotherapy, how would you take this detailed, how would you take this history more in detail to see if the child is receiving adequate physiotherapy for his age and his level of motor involvement? So who was doing the physiotherapy? Is it like the child is going to the physiotherapist every, say, twice a week, thrice a week, or whether the mother is doing it at home? How many times is it being done? Let's say mother say I do it twice at home every day. Each time I do it for 10 minutes. So you need to have more specific details about the type of physiotherapy, who's doing it, how long, and how many times a day, to be able to judge whether it's adequate for the kind of involvement that the child has, or the child needs more aggressive, more intensive therapy. Along with that, the child is also receiving occupational and speech therapy, and whether there's any history of surgery. So, what surgeries would a child with CP need? So, tenotomy or botulinum toxin for spasticity, or maybe squint surgery. So, those are the two common surgeries that these kids require. Immunization, so is going to be the same as per your national immunization schedule. What was the last dose and when was it received? And if the child has had missed doses, then what is the cause? Is it that the child is chronically ill? Maybe the child has had repeated aspirations, aspiration pneumonia, the child has required multiple hospitalizations for whatsoever reason it is, whether it's recurrent UTIs because of gallbladder disturbance, etc. So if the child has missed out on certain doses, why was the dose missed out is something that you should always ask for. Now, dietary history. So mention the feeding difficulty, whether the child is having vomiting, regurgitation, difficulty swallowing, drooling of saliva. How much time does the child need per feed? So any child who's having difficulty with swallowing, difficulty with your oromotor system will have or will take longer to feed. Whether the child is able to take solids or whether the mother has to churn it into a semi-solid and give it via a vati spoon. So what kind of preparation, whether the child is able to chew or is requiring semi-solid foods, association with drooling, coughing difficulty, and at the end, like any other case, you'll calculate the protein and calorie intake expected and the deficit. So family history in a case of CP, so you'll draw three generation pedigree chart. So three generation means the child, parents, and grandparents. History of consanguinity, like we saw, is important specifically because certain genetic and metabolic causes which mimic CP have autosomal recessive mode of inheritance. So consanguinity plays an important part there. History of seizures and developmental disability in the family. History of metabolic diseases in the family and stroke. So all of these are associated with autosomal recessive conditions which can run in the family. And that's why this family history is important to ask for. So socioeconomic is again going to be a modified Fukusami based on all those parameters. And very important in a case of CP or any chronic illness is going to be what is the level of education of the parents and what is KAP? So KAP is knowledge, attitude, practice. So what do the parents know about what condition or diagnosis the child has? What is their attitude towards it? So how aggressive are they with the kind of therapy that the kid needs? And whether they understand what type of treatment the child is requiring or is going to require and whether they're able to practice that. So let's say the child has been put on anti-epileptics and physiotherapy, whether all of this is really being practiced or not. So knowledge, attitude, practice are very important points that you need to mention in any chronic case. And looking at CP, which is a kind of disease which is going to require therapy lifelong, this aspect in social economic history should not be missed out on. So after all of this uh, history about starting from the chief complaints till your socioeconomic history, how are you going to summarize? So this becomes very important. Your summary in this case becomes super important. So let's just pay attention to that. So at the end, I will summarize this as a case of non-progressive motor disorder of cerebral origin. Now, why am I saying these points? Non-progressive is because The child is not having any regression of milestones. We just saw that. If the child has a regression, it points against CP. So delayed development, yes, but no regression. So it's a non-progressive motor disorder. Why motor? Because the motor system is getting involved. So the child has increased tone, spasticity. So that basically points towards motor system involvement. Of cerebral origin, why am I saying that? Because the child has history of seizures. Seizures, like we saw, originate from the cortex. So when there's history of seizures or there's history of global developmental delay, both of this point towards a disorder of cerebral origin. So when I say these points, these 3 points of non-progressive motor disorder of cerebral origin points towards the diagnosis of cerebral palsy. Now, what type of CP it is? So whether the child has spasticity or hypotonia, you will say it's a kind of a spastic CP, again, whether it's diplegia, hemiplegia, quadriplegia, monoplegia, depending on which limb is getting involved. So let's say the child has increased tone in the lower limbs. So I'll say this is a kind of spastic diplegia. Whether the child has associated convulsions or not. So in that case, you say that the child has a seizure disorder or epilepsy. So when you say epilepsy, you need to have at least two convulsions unprovoked more than 24 hours apart. So the child has had episodes of multiple convulsions in the past. You can safely say that the child has epilepsy. What is the etiology? So from the history, you'll be able to say whether the child has probably had a significant birth history, like he's not cried at birth, required resuscitation, or maybe the child developed meningitis in the neonatal period, whatever it is, depending on the history. So you will say probably the etiology is it could either be perinatal asphyxia, it could be meningitis, it could be infections, it could be conitis, etc. And at the end, you mentioned comorbidities like whether the child has contractures, bowel bladder involvement, squint, repeated respiratory tract infections, or any of the other complications like bed sores, etc. So that is how you summarize your history at the end of your questions that you've asked. So you will say whether this is a case of cerebral palsy, depending on whether it was a non-progressive motor disorder of cerebral origin. If that is the case, what type of CP, whether it was a spastic CP and what limbs were involved, and what is the etiology and associated comorbidities. So this is how you summarize CP. What is the definition of cerebral palsy? So it is a permanent disorder of posture and movement. So basically involving the motor system, right? Which can cause activity limitation. It is non-progressive or static encephalopathy, like we said. So that is, you will never have regression of milestones. And the insult has taken place in the developing fetal or infant brain. So the insult has to happen before 1 year of age. This is very important to know that this is the kind of little change that the definition has been made recently. And now they say that the insult has to be in the developing fetal or infant brain. So the insult has to happen before 1 year of age. This is the definition of cerebral palsy. Now, after having said this definition, what are the differential diagnoses or what are diseases which can mimic cerebral palsy? So common metabolic and genetic disorders that mimic CP, according to the prominent motor dysfunction, could either be metabolic or genetic. Again, this is a beautiful table which is given in the IAP guidelines, which kind of points as to depending on what type of motor involvement, whether it's spasticity, whether it's dyskinesia, whether it's ataxia, what underlying metabolic or genetic condition could this be which can mimic cerebral palsy? So in somebody who's presenting with spasticity, it could be Aicardi-Guthrie syndrome or leukodystrophies, metachromatic or adrenoleukodystrophies. Those with prominent dyskinesias could be because of DOPA responsive dyskinesia, or you can have folate deficiency Leishman syndrome. Disorders with predominant ataxia could be pontocerebellar syndrome or mitochondrial encephalopathies, mitochondrial cytopathies, etc. So you don't really have to, kind of know all of this, but it's just important to know that there are certain metabolic and genetic conditions which present with motor involvement and can mimic cerebral palsy. So this ends our discussion on history taking. So we were able to take a detailed history and give a set of etiologies and differential diagnosis at the end of history. I kind of briefly introduced cerebral palsy just in terms of the definition and how do you define what type of CP it is. But definitely the next session we look at examination in a case of a delayed development. With the examination, finally, we'll be able to give a diagnosis on the basis of both history and examination. So we'll look at the investigations and treatment, and we'll have a detailed discussion on cerebral palsy, where we look at the classification, etiology, and a lot of other things, especially viva questions that can be asked if you have a case of CP. So this concludes our part one of approach to developmental delay. I hope you guys found this session helpful, and stay tuned for the second session, which is going to be all of these interesting and super important topics, even from an exam perspective. If you have any questions, you can note it down in the comment section and we can discuss that. If you have any suggestions, you can also put it down. I will put a link to the presentation in the comment section so you can access that as well and you can have it for your reference. So that ends the discussion, and hope to discuss a lot more cases and see you soon. Thank you so much for watching the video.